All right, hello everyone, and welcome to the industry-supported panel session. My name is Jennifer Mann, and I am an engineer by trade and a technology advisor to Mass General Hospital's Hospital at Home program. And so, as an advisor to the MGH Hospital at Home program, I've learned a lot about how to do hospital at home in Boston, in the United States, right? And so what I love about this Congress is that it's an opportunity to learn about some of the key differences in the healthcare systems of other countries and what that means for doing a successful hospital at home in these other countries. For example, yesterday we heard about how in Singapore they have to deal with really sweaty patients who need to shower a lot and what that means for RPM. And so today we have an exciting opportunity to learn about the experience and the outcomes of Discovery Health launching a hospital at home program in South Africa. And so today I am joined by Laura and Malik, and I will let them go ahead and introduce themselves.
Thanks so much. So I'm Laura Curry, and I am the head of Discovery Healthcare Services and Strategic Assets at Discovery Health in South Africa. Discovery Health is an administrator and managed care service provider for Discovery Health Medical Schemes, which is a medical insurer in South Africa.
Great. And my name is Malik Majmudar. I'm a cardiologist and one of the co-founders and chief medical officers at Bioformis. For those of you who were here yesterday, I briefly introduced Bioformis, so I'll be brief today. Bioformis is a global technology-enabled care delivery company. And as I said yesterday, we're really focused on the transition of care out of the brick and mortar facilities to the home environment. But we do so across the entire care continuum. The focus today, of course, is around acute care and hospital at home, but we also do that for post-acute care and chronic care management as well. Again, we're super excited to be here to share our joint experiences with Discovery Health in South Africa.
Great, thank you both. And so a first question to Laura. So we know that South Africa has made a lot of really great efforts to improve the quality of healthcare since the 1994 elections. But like the rest of the world, challenges still remain. So what do you see as the biggest current healthcare challenges in South Africa?
So when we look at the South African population, we currently have about 60 million people, but only 9 million of those are actually insured with a medical insurance. And if we look or compare ourselves to healthcare services internationally, you can see that the number of hospital beds that we have available in the private sector is really not driving the hospital at home movement, because we do feel like we have sufficient beds at the moment, but the cost of care is really significant at the moment. So we need to really focus on reducing the cost of healthcare. What we've seen is medical inflation is increasing past CPI year on year. And if we don't find innovative ways to really reduce the cost of healthcare, we're going to land up pricing ourselves outside of the market. And if we really focus on reducing the costs of care, we are able to not only expand into the market opportunity of another 8 million patients that are employed but uninsured due to the cost factor, but even expand further and really just help the South African health ecosystem.
Great, thank you for that context, Laura. And so, Malik, question to you along the same vein. What are some of the parallels and the challenges between the healthcare systems in South Africa and the United States?
I love looking at these kind of slides because it's interesting. If you think about the deployment of these programs across the world, and luckily we have programs in US, South Africa, and other countries, the actual pain point that you're trying to solve is actually very different across different geographies. I mean, ultimately, of course, it's about providing acute level care in the home. But the reason health systems, payer organizations, or risk-bearing entities try to do this, as you heard Laura say, is actually very different. So it's interesting to compare and contrast US, where the primary impetus for doing acute care in the home during the pandemic and before the pandemic was really around bed capacity and capacity constraints. At least in the US, there's terms like ED overcrowding, If you look at just Mass General Brigham a few months ago, there were close to 60 to 80 patients, what are called boarders, waiting in the emergency room in the hallways, waiting to be seen and being admitted. So capacity really was a major constraint, both in the inpatient floors and the emergency rooms. But it seems not to be the case in South Africa, where they're saying in the private hospitals, it really has nothing to do with capacity, it's really have to do with cost. So I think it's interesting to compare and contrast these things to drive the right value propositions and the right education expectations for our customers to really get the clinical and operational buy-in to launch these programs and scale them.
Great, thank you, Malik, for so interesting to hear about some of those commonalities and differences. So Laura, a question for you. So yesterday we heard a whole panel discussion on patient identification and how that's even just a challenge for older groups or older programs that have been around for a while. So how did you go about identifying the specific cohort that you wanted to enroll in the start of your program?
So with our program, because we are part of the medical scheme, we did have a lot of data at our disposal. So we took the in-hospital claims for the full year period. We then broke it up into different diagnoses-related groupers. And from that, we then separated out the low acuity cases and the low case mix index. From there, we then looked at what services were those patients receiving in the hospital, and could we actually duplicate those services at home? We then landed up with a group of about 160,000 admissions that we believe annually can actually be eligible for hospital-at-home programs.
Great, thank you. And so Malik, would you mind explaining, so for programs in the US that are trying to identify and enroll patients in newer programs, what are they doing to grow and scale for impact?
Yeah, this is, to me, is a really interesting space because it's an interesting opportunity for us to collaborate with our partners and, again, across other geographies similarly, to really figure out what are the right patient populations that are not just eligible, will benefit the most from these kind of programs. In the US, just to give you an example, there's some pretty strict criteria called interqual criteria for hospital admissions. So first and foremost, in order to actually be eligible for acute care in the home, what you're really doing is doing a substitution of an inpatient hospitalizations for home. So you have to meet certain criteria. But within that criteria, as Laura was mentioning, there's different severities, acuities of illness. So how do you identify the patients who will, again, benefit the most, but also have the sort of lowest probability of adverse events? There are some very specific quantitative criteria we've come up with for each of the various conditions or diagnoses to help our clinicians identify these patients. I think there was a great session this morning and then yesterday really around how can technology enable identification, automated identification of patients within electronic medical records. I think not all the systems in the country are utilizing or leveraging those kind of tools just yet. I think lots of people are interested in doing that because at this point in time, one of the sort of challenges for us and everybody is, I don't know the denominator. And you've done a great job of putting it on a graph here, how you really quantify the true opportunity. But what we don't know in a clinical environment is what is the true denominator of eligible patients. And if you try to quantify some of these criteria by various conditions and embed it in the EMR, you could truly in a real-time manner understand in a daily basis, a monthly or annual basis, what % of our true admissions are actually eligible. I think there's a lot of work and opportunity to do that and automate it, but those quantitative criteria is how we do it today.
Great, thank you, Malik. Yeah, we can have all of the cool technology and protocols in place, but if we're not enrolling the right patients, we won't have a successful program. So thank you. So Laura, question for you. So I know that this program is still pretty young. You launched it back in January of 2022, so a little over a year and a couple months old. So what are some initial outcomes and to date, and what aspirations do you have for year 2 and beyond for the program?
Right, so when we look at our admissions for 2022, since January last year, we've seen 115 patients being admitted into our program. And we're quite happy with the outcomes that we've achieved so far. The average length of stay is just over 5 days. Care escalation rate is 8%. We've been able to reduce the 30-day ED utilization rate and really drive down the cost per admission, so to between 29 and 47%. And that variability is really dependent on the care pathway. So the 29, or the lower end, is where the patient was first admitted into hospital, early discharged, and then continued care in the hospital at home. And the higher end is where we were able to fully substitute with a hospital at home rather than an in-hospital admission. And that was 41% of our cases. Where we haven't quite yet seen a good outcome is the 30-day readmission rate. So we can see that we are slightly higher than in hospital. And although this is a small subset of group of data, and when we look at readmissions, we look at all causes. So it may not necessarily be related to what they were treated with at home. We do view this as a really great opportunity to now further expand our program and offer support to our patients post-discharge of the acute program, and really make sure we can significantly reduce that rate. And if we look forward for a couple of years, we currently this year want to achieve 5,000 admissions in the home, and in the next 2 to 3 years achieve 50,000 admissions in a year in the home. We showed you in the previous data set that there are these eligible admissions, and so we really want to rigorously scale this model.
Wow, those are some great ambitions. Can't wait to follow your work in the coming years. So Malik, taking it back to you. So in the US, how are health systems making an impact with hospital at home?
You know, what's interesting about this data is how remarkably similar it is to a lot of the data we've seen published from folks like at Brigham or Mayo or Mount Sinai. If I look at the diagnoses here, the top 3 or 4, those are exact same diagnoses, even in our own program in the US, that make up for a majority of the hospital at home admissions, specifically around pneumonia, heart failure, cellulitis, and UTI. If you look at average length of stay, a lot of the published data suggests that average length of stay in our biopharmacy programs in the US is around 4.2 to 4.6 days. I think we're slightly higher, 5.3, so again, very similar. And if you look at the data published by Dr. David Levine around cost reduction, I think that paper, if I remember correctly, was 40% reduction in cost, which is remarkably similar to what you saw in South Africa. So I feel like from a clinical perspective, the eligible populations, the length of stay, the escalation rates, and cost reductions are very similar, which is very promising for all of you out there thinking about launching programs around a hospital at home in your different geographies and different countries. I think if you look at this impact and scale in the US, one of the biggest things, of course, is very tied to also payment models. Part of the slow adoption of acute care in the home in the US has been some hesitancy from certain health systems around a permanent payment model for some of these programs. But right now, under the CMS waiver, we've had close to 300 hospitals that have adopted these programs. And those programs are slowly scaling. I think we're still awaiting large data analysis in some of these populations to really drive policy and permanent payment for some of these models from CMS and government programs. But I think, as you've heard in the conference of the last 2 days, there's been incredible adoption and growth in various geographies, including the US.
Thank you, Malik. And just a reminder to the audience that if you have any questions, you can submit them in the Q&A in the app, and we'll see if we have time to get to them at the end. So Laura, another question to you. So I was fascinated by this discussion we had earlier about some of the key differences in the payers and providers and how they interact in South Africa. And so how has Discovery structured their program, and how do they work with hospitals and providers?
So Discovery is quite unique in the fact that we are both payer and provider of services. So like I mentioned earlier, we've got Discovery Medical Scheme, which is the non-profit medical insurer. And Discovery Health is the administrator of that medical scheme. And Discovery Health then own the subsidiary companies that offer the care services to the patients. And so being the payer, we're able to, try and see how we can look at defining benefits or changing benefits around the hospital at home model. Because what we do face as a challenge in South Africa is that our providers or our physicians are all autonomous. So you really have to get them to buy into the hospital at home setting. We don't own a brick and mortar hospital like many hospital at home programs around the world do. And these doctors really need to voluntarily want to look after their patients in this new care setting, in this virtual remote world. And so while we haven't quite seen the great adoption that we would like, we do have that opportunity as the payer to define those benefits and hopefully look to scaling it up quite rapidly through that.
Great. Thank you, Laura. And Malik, question for you. So relative to reimbursement, how concerned are healthcare leaders in the US about the long-term outlook for hospital at home?
Yeah, let me make maybe one comment on what Laura just mentioned around patient enrollment. We'll come back to the long-term impact. I mean, this is really interesting, right? We're talking about this idea about depending on which stakeholder is interested in deploying a hospital home program, whether it be a health plan versus a provider group, and depending on where the patient identification and patient enrollment is coming from, there's several different types of challenges. So in the US, at least for biopharmas, majority, I mean, in the US in general, majority of hospital home programs are led by hospitals and health systems, where they're diverting patients from emergency rooms or inpatient floors to the home environment. So clinicians have direct access to all the clinical information needed to identify patients, enroll them, and then get them into the programs. I think it's a different set of challenges what you're describing, Laura, around really if you're a payer organization with no direct influence over the clinical care setting or direct access, how does one identify them? And how does one think about collaborating with your clinician partners as well as your health system, hospital partners to really drive adoption and scale these programs? I think that's not so unique to Discovery Health, but it's a unique challenge depending on which environment you're coming from. Even in the US, there are certain programs where they're led by insurance companies. They have a very different rate of enrollment and patient adoption between what we call a payer-led program versus a provider-led program. I mean, patients inherently trust their doctors. When doctors believe in the program, believe in the outcomes, and recommend a program like this, we see incredible adoption by patients, acceptance, and the majority of those patients have a great experiences in the home. So they actually want to go back and do it again the next time around. Whereas if it's purely a payer-led program, you have to have the right partnerships. Otherwise, it feels like a really distant program.
No, I completely agree. And I think the one thing that we really want to focus on is key opinion leaders and endorsements from our providers in South Africa. One of our leading admitting doctors, Dr. Govender, is actually here today with us at the conference. And it's people like him that we really want to partner with to go out and convince other doctors to utilize this care setting for their right patients.
Great, thank you both. And so I think we have time for one last question here. So question for you, Laura. It's great. I know there are probably a lot of young programs here and people getting ready to launch programs. So I'm sure they would really benefit from hearing about some of the challenges or lessons learned that you experienced in the first year of launch. So could you please share some of those lessons learned?
Sure, yeah. So the first one was this perceived compensation loss by the physicians. And so what we did to mitigate that was we paid our providers an incentive of an extra 30% should they enroll their patient in our hospital at home program rather than in hospital, obviously as long as all the clinical criteria had been met. So we were able to add that. The second was the perceived medical legal risk, but we worked really closely with the insurers in South Africa. They came and saw our program, our algorithms, our technology, and they were very happy to underwrite any doctor who wanted to enroll into the hospital at home program. I've spoken about the time to scale. Something that's been mentioned yesterday and today quite a lot is the trust factor. So what we've seen is a lot of our physicians, they know their care team, they know their nurses, they can trust them. And when we launched, we had a huge array of nurses that went out into the home environment and did the treatment for the doctors. So the doctor had multiple nurses, couldn't really build a relationship with them, didn't feel it was appropriate. And so what we've gone now and done is hire what we term clinical consultants, but they are very highly skilled ICU and trauma nurses that then oversee all the services on the ground for that doctor and their cases. And they're able to then build that relationship with that doctor and that trust that we spoke about. And then when we look at infrastructure and connectivity operational risks, so before we started our program, we really sat down and made an extensive list of all the risks that we could potentially face and how to mitigate them. One of them being load shedding. If you don't know what that is, in South Africa, we don't have sufficient power to meet the demand in our country. And so depending on what level we are, for certain hours in the day, our power gets switched off. So we've put UPS batteries in the home, which can connect to the patient's Wi-Fi. We've partnered with providers that have rechargeable devices and hold charge for at least 18 hours so that that continuous monitoring of that patient is not interrupted. What we didn't have on our list and what we experienced last year while we had patients admitted was devastating floods. It was in one of our regions, roads, bridges got washed away. It wasn't on our list. We had to very quickly, in a very small time window, decide what to do. And we were able to take those patients and put them back into the hospital. And I think to the point that was raised yesterday, we really do ensure that, every patient has a bed in the hospital, should they need it for the care escalation. And that was probably why our escalation percentage was slightly higher, as you saw earlier.
Great, thank you. Well, I think that's about all the time we have today. So let's give a round of applause for our panelists, Laura and Malik. And we didn't have time for questions, but if you do have any questions, please grab them during a coffee break and pick their brain. And thank you all.